The Annular Ligament by Lott. The annular ligament covers the proximal radial head, and its attachments are the anterior and posterior margins of the radial notch on the ulna, and it has a tight fit around the radial head in order to provide maximum support of the radial ulnar joint. The ligament stabilizes the proximal radial ulnar joint by keeping the radial head inside of the radial notch of the ulna. It stabilizes the joint during elbow joint motions, more specifically during pronation and supination, in which the radial head rotates against the ulna to provide range of motion. The annular ligament is typically injured due to repetitive motions of the forearm and radial ulnar joint. Athletes participating in year-round training of the same sport are especially prone to annular ligament injury if they are constantly using the elbow joint. Dislocation of the radial ulnar joint may also damage the annular ligament when the radial head is displaced and pushes against the ligament. The motion for this is pronation of the hand with slight flexion of the elbow, and a varus stress is applied to the elbow joint. If an annular ligament is injured, patients may experience pain on the lateral side of the elbow when they make movements such as throwing, as well as with palpation. Swelling may occur along the joint, accompanied by weakness in surrounding muscles of the arm. It is also common for patients to complain of pain and numbness spreading down their forearm and into their hand. A partial tear of the ligament may also be referred to as a grade 1 or 2 sprain. With grade 1, the ligament is stretched and there is mild pain in the structure due to small tears being formed in the fibers. In a grade 2 sprain, the ligament is stretched further and fibers become loose. The patient has a loss in strength of the joint and laxity is present in the ligament. On the other hand, with a complete tear of the annular ligament, also known as a grade 3 sprain, a complete separation of the ligament's fibers occurs and the ligament loses its function of the joint, allowing the radial head to move in and out of the radial notch. There are no special tests for an annular ligament tear, but palpating over the radial head will present pain in a patient with a tear in the ligament, and an MRI may be helpful in diagnosing a tear in the ligament. Differential diagnosis of an annular ligament injury includes lateral epicondylitis, a muscle strain on the lateral side of the elbow, and radial collateral ligament tears. These all cause pain on the lateral side of the elbow, and therefore they may be confused with an annular ligament tear during evaluation. People that often injure the annular ligament include athletes participating in year-round sports that include the upper extremity, those involved in work that requires repetitive supination and pronation, and also children due to the laxity in ligamentous structures in their elbow joint. Patients may be predisposed to an annular ligament tear if they dislocate the proximal radial ulnar joint, as well if they are often performing repetitive supination and pronation. Laxity in the annular ligament may also predispose patients to a tear because it allows too much motion of the radial head in the radial notch of the ulna. There is no mulligan technique for an annular ligament tear. Treatment for a partial tear includes rest, immobilization, cryotherapy to reduce swelling and pain, and the use of NSAIDs. Surgical treatment may be required for more severe tears such as a complete tear, or if a partial tear is not beginning to improve over time. Surgery is only recommended if it is an absolute necessity for an annular ligament tear, just as it is with any other injury in the body. Immobilization of the elbow joint is recommended for patients with a partial ligament tear, and this typically includes a sling to prevent motion in the elbow joint. Referral to an orthopedist is recommended for patients with complete ligament tears, or if an MRI is needed to view the ligament. Preventing an annular ligament tear includes limiting repetitive and constant pronation and supination of the hand, reducing or stopping training and strain placed on the joint if pain or swelling begins to occur, and protecting the joint is also a prevention technique to limit chances of radial head dislocations. My PCOT analysis included a 6-year-old female with chronic radial head dislocations in her left arm. The injured arm was originally placed in a sling to immobilize the joint, and after the sling was unsuccessful, surgery was performed to use the ipsilateral palmaris longus tendon to reconstruct the annular ligament. The surgery was successful, and a follow-up 2 years after the surgery showed that the ligament had held the radial head in place, as no dislocations occurred between the time of surgery and the follow-up appointment. Thank you for watching, and I hope this helps your understanding of the annular ligament and its functions.